Welcome to part one of our gut health series. My name is Megan Ellison. I'm a registered dietitian nutritionist and a certified diabetes care and education specialist. And I have a passion for gut health. I see a lot of gut disorders in my practice, and we're going to go through some things top to bottom today that you can be thinking about. And then in our next class 2 weeks from now, we're going to get a little bit more into some specifics on some of those specific disease states or syndromes. You are in a webinar, and so I cannot see you or hear you. You are welcome to go ahead and put things in the Q&A. I will check the Q&A every so often. Let me just pull that up right now. And the chat is not going to work. So we've disabled the chat, so you only have the Q&A to work with. So I just have to go to one place. So welcome. If you have any questions or if you have any comments or things to share, feel free to put them in the Q&A box. And let's go ahead and get started. You may have heard this quote before from Hippocrates. Something along these lines: all disease begins in the gut. And I like to flip it on its head and say all health begins in the gut. The food that we're taking in, the air we're breathing, even stress management can be affecting gut health, which we'll talk about as we go along. But the gut is really that interface with the world. So many of you are probably thinking about like the gut being inside our body, but those who are in this area of medicine really think about the gut as being outside the body. And someone just described it recently as like a donut. So if you think about a donut and the hole in the center of the donut, how the hole really isn't the donut itself. It is actually exposed to the outside. It's like that, our whole alimentary canal from the mouth to the rectum is really exposed to all of the things that we are exposed to, just like our skin is exposed to things. So it's really interesting to think about just that interface. And we'll talk about that a little bit as we go along here. And I think I skipped, let me skip. Here's our sponsor slide. I just want to make sure that we recognize Stilly Valley Health Connections, who is sponsoring this class. You registered through them. They have a lot of other classes that they host, even classes on site at their Stilly Valley. It's like a community wellness center there, and they actually have a teaching kitchen, and we do cooking demos there in person. So if you are in the area in Snohomish County and want to join us for some of those live classes, that would be really fun too. Here's what we're going to cover tonight. So we'll describe some common GI complaints, identify a few nutrition and lifestyle interventions, and then throughout, we're going to be talking about developing your support team, because gut disorders are very complex. And so you may have different specialists who can help you along the way. And then I'm going to give you some homework to do so that you can basically think about your own scenario and maybe do some detective work over the next couple weeks, maybe keep a food journal. Definitely, if you have a pen and paper for tonight, you might want to jot down some notes or things that you might want to look into. And then our classes, our second class in 2 weeks, we'll come back together and talk through some more strategies on addressing some of those concerns. And I do want to just make the disclaimer that, this is educational in nature. I am not your specific registered dietitian, and this is really a class just for sharing information. But if you feel like, you do need to see a specialist, talk with them, reach out, get, a lot of times your primary care is a good place to start so that you can get referred to those specialists. And if you don't have a dietitian, feel free to reach out to us at Sound Dietitians. That is my private practice. Or eatright.org is a good resource to find a dietitian in your area. Okay, so we're going to start at the top. So when we're thinking about, this whole alimentary canal, or really like the entire digestive tract, it really begins, with what we're doing in our mouth. It's the food we put in our mouth, the other substances, like, are we smoking? Are we ingesting alcohol? What are the things that we're eating and drinking make a huge difference. And digestion actually does start in the mouth as well. So both mechanical and chemical digestion begins in the mouth, specifically with our salivation and some of those enzymes. Those are breaking down carbohydrates. So the starch breakdown starts in our mouth. And then, of course, our chewing, our teeth. If you don't have teeth, maybe you are able to chew some things without your teeth. I know I have quite a few patients who have full dentures and they don't use them for eating. And so maybe you're doing a little bit of a softer diet that can actually change things later down because maybe you're doing a little less fiber. And so you might end up with some changes in stool patterns. But the mouth is a really big deal. And so many of my patients that have gut disorders, just slowing down and really focusing on chewing food and enjoying, like savoring our food, really does help with lower down GI complaints. Because if you're starting with breaking down the food better in the first place, then it's easier for your stomach and it's easier for your digestive tract. We may tend to eat a little less as well when we're enjoying it more because we're slowing down and listening to our body and listening to those fullness cues. Also, the mouth and especially the nose is really where we are identifying any foods that seem to be off. So if you have had foodborne illness in the past, you are more susceptible to getting it again in the future. And that really can lead to things like post-infectious IBS, to risk for SIBO or small intestine bacterial overgrowth. Of course, just like, being very sick in general for a few days. So start with, your visual cues, use all your senses, your visual cues, your smell, and then of course taste. And it's not worth it to have a foodborne illness. If something tastes off, just throw it out and start over. Lately, I have had quite a few patients with dental issues like infections or multiple cavities that actually we have figured out has been contributing to their small intestine or even large intestine complaints. And so we do know that, it can be the mouth oral microbiome can be a reservoir for basically reinfecting yourself because you're swallowing all the bacteria and those yeasts all the time. So if you have not been to the dentist lately, this is just a little reminder that that really does make a difference. And recently, I just had a patient who we figured out, once he got all his cavities taken care of, and because he had small intestine bacterial overgrowth, that his issue is really coming from his mouth. So that is a possible thing. So definitely take care of your oral microbiome. So some things to think about with that. Are you brushing your teeth every day or multiple times a day? Flossing or water pick if you can't do floss. Are you seeing your dentist or your hygienist every 3 to 6 months, depending on what their schedule is, their recommended schedule is for you? Addressing any cavities or gum issues, getting those, the root canals or the things that you really might not want to do. So maybe you're putting it off, but getting them done. Hydrating between meals and swishing of the water can actually be even more beneficial for, rinsing the mouth and getting some of those things that the bacteria can feed on, like sugars, out of your mouth. Do be careful with things like gums and mints and candies because a lot of times those contain either sugar themselves, which can be a risk factor for dental cavities or dental caries, but also the sugar alcohols. And a lot of my patients are very sensitive to sugar alcohols, even the sugar alcohols that they sometimes put in toothpaste. So most toothpastes on the shelf have sugar alcohols in them. And if you are someone who is very sensitive to them, you might be swallowing enough, like small amounts, but enough that they can cause you some GI distress. So that is actually something to look at. And they do have, some brands have without the sugar alcohols, like the one I'm thinking of is Burt's Bees, that still has the fluoride in it if you really need that for your cavities, but doesn't have the sugar alcohols in there. So that might be something to check out. So one of the people, really important healthcare team member is your dental team. So let's just talk about chewing a little bit more. Eating fast is a problem here. We're very busy. A lot of us were taught to clean our plate, eat fast, go on to the next thing. Some of you may have grown up in big families where you were competing for food with siblings. Yeah, so, we lead kind of busy lives and don't really take the time to slow down and enjoy our food. And that can lead to overeating. So you're really eating past that fullness mark without even really realizing it. You've probably heard about the, concept of it takes 20 minutes to really feel that fullness. And we do know that that's true. So the stretch receptors in the stomach, once you are eating and getting that stretch receptor happening, then that cue goes up to your hypothalamus to tell you that you are full, but it does take some time for that to happen. So one of the strategies with that is to just aim for an 80% full. So you're not trying to get all the way to 100 with every meal, but basically you're getting like 80% of the way there where you're shutting off hunger. You are very satisfied. You know that you're going to be able to have like a meal or a snack a few hours later, and you're not so full that you're going to be uncomfortable. That 80% full mark does tend to lead to some, benefits as far as like other conditions. So like if you're having reflux, for example, so esophageal reflux disease, GERD, or if you're just having like what we sometimes call heartburn on a regular basis, the amount really matters, the amount of food you're taking in at one time. So if you are overfilling the stomach all the time, it is going to be more work. It's going to take longer to leave the stomach. You have more chance of reflux during those times. The other thing that some people don't know about is swallowing air. So if you are eating quickly, a lot of times you will actually take in more air while you're eating, and that can lead to some bloating that is just related to the air that you've swallowed, and that's known as aerophagia. This can also happen if you are a gum chewer, so you're like constantly swallowing something during the day. Or sometimes we see this with our athletes who are taking in a lot of air during exercise. If they're like taking in the air and then swallowing their spit and taking their water and then getting kind of bloated, that can actually just be bloating from excess air intake. So do slow down, do think about that 80% full mark and really enjoy your food. Okay, next in line is the esophagus, and we have a very complicated swallow function, a lot of coordination going on with that, and many things can go wrong. So for example, this has probably happened to you where you can inhale some food instead of actually swallowing it into your esophagus. It's going in the wrong tube and can end up in the lung. The esophageal muscles themselves can become uncoordinated, and things go in waves. And right now I have a handful of patients in my schedule who have dysmotility in their esophagus. And so it's just very hard for that food to move down in a coordinated manner. And that can be from, several different causes. One of the causes could be narrowing of the esophagus. Sometimes the cause is chronic reflux, so chronic acid reflux from the stomach up into the esophagus that's changing the tissue. There's another condition called eosinophilic esophagitis, or EOE. And that's more of like an immune type condition, and that can lead to some narrowing of the esophagus and definitely inflammation of those tissues. And we don't want to just let that go. Like if that's happening for you and you haven't seen someone, that is a really big deal, because if it's like from reflux, for example, we want to take care of that, because that is a risk factor for developing cancer down the road if you just don't manage it. And EOE is important to get checked out, because there are some specific things that you can do for that. So for looking at these conditions, the swallow function itself can be evaluated by a speech language pathologist. Of course, your gastroenterologist would be someone who could actually go in and look with an endoscopy, so a top-down scope, where they can look at your esophagus, they can look at your lower esophageal sphincter between the esophagus and the stomach, they can look for a hiatal hernia, which we'll talk about in a minute, they can look in all the way into the stomach, which is really nice to see if anything's going on there. And then also an allergist might be part of your team if you're looking for something like eosinophilic esophagitis, so something more like immune and allergy related. Okay, let me just see if there are any. Let me see, there's one thing in the Q&A. The question is, what is sugar alcohol? So sugar alcohols are sugar alternatives. They are sweet. They have a little sugar molecule, but we don't digest and absorb them the same as sugar. However, like fiber, we don't digest and absorb fiber, but like fiber, they can be fermented by our gut bugs. They can be fermented by bacteria, by yeast, by archaea. And so when they get into the GI tract, some people have bloating and gas because of that fermentation process. And so when you're looking at your labels, if you're looking for sugar alcohol in the nutrition facts panel, you can look at the line under total carbs, and then sometimes it'll say sugar, and then it'll actually list out sugar alcohols. You can see if it's there. Or if you look in the ingredient list, anything ending in TOL, so like sorbitol, mannitol, xylitol, erythritol, those are all sugar alcohols, and they're often found in things like chewing gum, mints, sugar-free items, so sugar-free candies, sugar-free ice cream. And if you're doing multiple of those a day, or if you're like chewing gum all day long, then all of a sudden they really can start adding up and causing some GI distress for people. And some people are actually quite sensitive to sugar alcohols. Great question. Okay, so check your labels. Things you can do. So thinking about the mouth, the esophagus, slowing down, smaller bites, chewing well, have fluids with your foods that helps move things through the esophagus. Please do not ever take a pill without fluids. So I know sometimes it's kind of a macho thing to do, to just like pop a pill and swallow it, but that actually can cause some significant damage, not just from medications, but actually like supplements even. Like if a turmeric opened up in your esophagus, that would be a bad day, because it is an irritant. It's an actual irritant to your lining, basically the skin or your endothelial layer in your esophagus. So please don't take pills without any fluids. I will say, if you are having a swallow function issue, like dysphagia, you may have heard of, water, ironically, is the hardest to swallow, partly because there's just like not a lot of things there to sense. It's very neutral. And so for some of my patients who do have dysphagia or just a swallowing disorder, we'll flavor the water or add some bubbles. So the flavor helps. A consistency change helps, like carbonation, or even sometimes patients actually need to thicken their fluids in order to be able to swallow them better. Also, moist foods that hold together are easier to swallow. Rice is one of the hardest because it's particulated and dry, and can easily be aspirated. So sauces help where it holds things together. And again, like you would see a speech language pathologist to identify what thickness of things you need if you are having a swallow disorder. Listen to your cues, slow down to prevent the overeating and the heartburn. And then if you know that you have some trigger foods, like spicy things or citrus, then think twice before you have those things. And a registered dietitian is the person to talk with about, that kind of thing, like figuring out what are your triggers, figuring out how and how much you can have without causing issues. The whole like emotional eating and binge eating and slowing down and kind of being in touch with your hunger and satiety cues, that would be a registered dietitian that could help you with those things. Okay. So moving on to the stomach. You may have heard, or you may have this yourself, hiatal hernia. That is a part of the stomach where it's bulging up into the space between the diaphragm. So your diaphragm is this big muscle that goes all the way around your entire abdomen, and your esophagus goes through that diaphragm to connect to the stomach. So sometimes what happens is a little bit of the stomach just pooches up into that space, and that's called a hiatal hernia. A risk factor for that is overweight or obesity because it's putting more pressure there. But also, this can be a genetic thing, like my mom has one, my grandma has one. I suspect I have one. I haven't actually been diagnosed, but I do, easily have reflux. So that can be part of why reflux can be an issue for some people because it puts pressure on that lower esophageal sphincter, and so things can stay open a little bit. And then if that's hanging open, you have more chance of that acid coming up into the esophagus. So sometimes we call it heartburn. It's heartburn if we feel it. And that pain actually is really kind of interesting because sometimes people feel it in the center of their chest. Sometimes it radiates, how our nerves are around our body. They radiate around the sides of our body. So sometimes people actually feel heartburn kind of on their side. For some people, it might be silent, like you might not even know that the heartburn is happening. And so that's where, maybe an endoscopy would identify like, oh yeah, you've had reflux and you have some tissue changes and you might not even know. Sometimes a red flag for this is if someone is coughing all the time or they wake up with a little bit of that like acidy taste in your mouth in the morning. That's a red flag to maybe talk with your provider or your gastroenterologist about it. Okay, indigestion, or another term for that is dyspepsia, affects 1 in 4 people. So about 25% of us in the US each year have some amount of dyspepsia. And for some people, though, that can become more chronic or severe. It's basically just like severe indigestion. And it's helpful to talk with a gastroenterologist about that and maybe a registered dietitian as well, because sometimes it is just like, oh, you're overeating or the types of foods you're having is a little too much. But you don't want to let it go and be chronic without it getting checked out, because you could have something like actual gastritis, which is inflammation in the stomach lining. And if that's happening, we want to know that so you can get treated before it becomes the next thing in the line here, the peptic ulcer. So you could actually have an open sore in the stomach lining if you let that go too long. Other things that a gastroenterologist could check would be like gastroparesis. So gastro meaning stomach, paresis kind of sounds like paralysis. So it's basically like a slowed emptying of the stomach. And that can be caused by different things. I often see it in my practice related to uncontrolled blood sugar because I work with a lot of patients with diabetes, and that is one of the causes of gastroparesis. But there's other causes as well. So if you're feeling like your food is hanging out for a really long time, you're just like digesting, or you like have a dinner, you go to bed, you wake up the next morning, you feel like you still have the salad in your stomach from the night before, that could be gastroparesis. So it's something to get checked out. And that would be kind of opposite of a rapid gastric emptying scenario. The most common reason we see this these days is due to a Roux-en-Y or a gastric bypass surgery. And you can have something that's called dumping syndrome, where basically you're dumping the food so quickly into the small intestine and out of whatever stomach you have, whether it's a little stomach or a normal stomach. But if things are really leaving the stomach quickly into the small intestine without having the churning, so both the mechanical and the chemical digestion happening from the hydrochloric acid, then that dumping syndrome can cause quite a bit of discomfort, because if you're not breaking things down, then all of a sudden it's going into the small intestine, and then the small intestine has to deal with all of this substrate all at once, and you can have some osmotic action where it's pulling water then into the small intestine, so some cramping and pain. So, for either of those two things, slow or rapid emptying, we would want to get that checked out. And there's things that we can do diet-wise. Okay, so common culprits, we already talked about. Obesity is associated with that hiatal hernia risk, eating too fast or too much all at one time, so volume. Caffeine intake can relax that lower esophageal sphincter, so do be careful with the coffee. And then the coffee can also be a little acidic, so it could be a double whammy for some people. Spicy and acidic foods can cause extra heartburn for some people. And then high fat meals. So fat actually slows down that gastric emptying into the small intestine. So literally the whole meal is hanging out longer, so then you have more chance for that reflux to be happening. Also, tougher proteins and just like really high protein intake will do this, because literally like the stomach is working hard to mechanically and chemically digest those proteins. And so your food is just hanging out a little bit longer, and then you have more chance for indigestion and reflux. Chronic or excessive alcohol intake, or your non-steroidal anti-inflammatory, like over-the-counter medications, can cause some damage to the actual tissues. So, be careful with those. And then we talked about the peptic ulcers. So the number one cause of peptic ulcers is a bacteria called H. pylori, and you can get checked for this with your gastroenterologist. And if that's happening, there's treatment to get rid of that bacterial infection. We mentioned that uncontrolled blood sugar can cause that gastroparesis or delaying of stomach emptying. And then bariatric surgery is the main risk factor for the rapid gastric emptying. And if you're having any of these things happening, as far as helping you with behavioral modifications, a registered dietitian is a good person to see. So some things that you can do right off the bat, planning ahead for your meals. And when we plan ahead, we tend to eat a little bit better, but also that can set us up for eating at better times. So a lot of times I see people who are just like skipping breakfast, sometimes blowing past lunch. They get to the end of their day, super stressed, super hungry, and then overeating at one time, which of course would cause some GI distress. So planning ahead, having your snacks with you, planning ahead for a breakfast in the morning, all of these things where you're like eating smaller meals at more regular intervals. The body and like the stomach especially is primed to digest some food about every 3 to 4 hours over the day, because that's how our blood sugar regulation goes with food intake. Usually we have a little bit of increase and then a decrease with our blood glucose, and then we're hungry again like 3 to 4, sometimes 5 hours later if we had a larger meal. And then you've got this acid with nothing to work on if you're skipping, your lunch, for example. So make sure you're taking time during your day for eating, for nourishing yourself, for fueling your day. Take your breaks. That will help with even like the stress management piece of things, but also give you some time to actually have a snack or have a meal. Speaking of the stress management side of things, you can actually impact your stress hormones and calm them down with something called diaphragmatic breathing, also known as belly breathing. Some of you may be familiar with this if you've done like yoga practices where you're breathing really deeply into the abdomen. You're not doing the shallow chest breathing that we often do throughout our stressful days. But you're really getting into that lower part of the abdomen, and the belly is expanding with the breathing. So if you just put your hand on your belly and another hand on your chest, think about how your breathing is right now. Mine is pretty shallow because I'm doing a lot of talking. But if I slowed down and expanded my belly and breathe that way, it instantly, I do feel more calm. A couple minutes of this we know can lower blood pressure, lower those stress hormones, get you out of what we call the sympathetic side of the nervous system, which is fight or flight, fight, flight, or freeze, and into what we call the parasympathetic side of the nervous system, which is also known as rest and digest mode. So literally a couple minutes of that deep breathing before a meal, for example, can help prime you for better digestion. It coordinates your digestion, coordinates release of stomach acid, release of pancreatic enzymes and bile, your sphincters, and even like the motility through your gut. So going into a meal, less stress can be really helpful. And then of course, if you're doing that, then you are probably also going to be more mindful as far as your portions and slowing down a little bit. You can also keep a symptom journal to try and identify your triggers. This is really helpful for people who are like, I don't know what's going on. It's really hard to remember from day to day, even like what we're eating, but then also like our response to the food. So if you keep a symptom journal and bring that into your dietitian or your gastroenterologist, that can be really helpful for figuring out what's going on with you. Definitely, substance use decrease. So smoking, alcohol, other medications, pain management stuff, managing your blood sugar well, dietary patterns and lifestyle. And then I would definitely, if you're on an acid blocker, or if you are just like popping the Tums like they're candy, definitely talk to your provider, because that is not a long-term solution. And so we want to address like the underlying thing that's going on there and not just try and put a Band-Aid on it. Those acid blockers are really not meant to be long-term used from a nutrition sense, especially. Like I get worried because then we start seeing things like lower absorption of your minerals like calcium, iron, magnesium, lower B12 absorption. So, they're not without risk. So for some of these things, you might be working with a registered dietitian, you might be working with a therapist. If you are in constant fight or flight, constant stress, being able to calm down and get into that rest and digest mode might be really difficult for you. So a therapist can help with working through some of that. Maybe your primary care doc, if you are looking for some pain management strategies or help with smoking cessation. Your endocrinologist, potentially, if you have diabetes and you're trying to get your blood sugar under better control to then help your GI symptoms. So you might have multiple people who could be of support. From a food side, let's talk a little bit about that. So slowing things down in the stomach, like literally hanging out longer, so slowing that gastric emptying. High fat will do that, even heart healthy fats. So it doesn't matter like that it's avocado or olive oil. It's really just the amount of fat in that meal or that snack that or that milkshake that's going to do that. So at the stomach level, things will slow down. Now, this does not mean that you will have slow motility in your GI tract, like your, small and large intestine, you could have slow at the stomach level and fast on the back end. Those both can be happening at the same time. But thinking about like upper GI, so reflux chance, high fat is going to slow down at the gastric level or the stomach level. Same thing with tough proteins, high fiber even. So actually this is one of the strategies with feeling full is to have more fiber, have more vegetables in your meal. But if you're struggling with gastroparesis, then maybe we need to alter that fiber. We need to chop it up. We need to cook it well. We might need to blend it. There are some strategies there. Just sitting even slows things down. So you might want to take a walk if you're feeling like things are hanging out really long in your stomach. Take a walk after a meal. Speeding things up. So simple sugars and carbohydrates are the quickest to leave the stomach. So if you have rapid emptying, that would be something you would be concerned with. The fluids with the meals help move things through. So again, like if you've got slow, then you're going to add some fluids to help move it through. But if you are on the fast end, you might actually avoid fluids during that meal so that you're just able to digest the food. And then you would put your fluids in between the meals. Blended foods will be easier, like a smoothie, for example, is not going to hang out with you as long as a parfait. So even though it's a lot of the same ingredients, like yogurt, fruit, maybe a little bit of granola with the parfait, when you blend it up into like a smoothie, it's already partially broken down, so you have less work to do. So it's going to leave your stomach a little faster. Okie dokie. Let's look at, let's see if there are any questions. Okay. Alrighty. So we are on to the digestive superstar. So this is where a lot of digestion and absorption happens, is in the small intestine. And we call it small, but it's actually the longest part of our alimentary canal. Most people, it's somewhere between 20 to 25 feet long, which is just mind-boggling to think about, like how it is in your body and 25 feet long. And it also has a lot of surface area. So we actually have the surface area, the estimated size for, the average person is about the size of a tennis court. So if you think about a tennis court with like a smear of peanut butter over it, like that is the amount of surface area for all of that nutrient absorption that happens. And the reason that we have that amount of surface area is all those villi in the gut. They're like finger-like projections that basically make you have a lot of surface area in a small tube. And then on top of the villi are microvilli. So, even more detailed than this little picture shows here. However, the small intestine, so even though it is like the longest and we do a lot of work here, a lot of nutrient absorption, it doesn't stretch the same way as your large intestine or your colon. And so sometimes people are actually having some pain because of gas. If you have excess gas in the small intestine, that can actually be quite painful. So for example, my patients who have small intestine bacterial overgrowth, where they are maybe producing a lot of hydrogen in their small intestine, that gas is not meant to be there in that quantity. And so you can have a lot of GI distress with that. Digestive enzymes in the small intestine, they're basically released both from the pancreas. So you may have heard about pancreatic enzymes. That's our main digestive enzyme. So the pancreas releases enzymes that go through this little duct called the common bile duct and get dumped into the small intestine, where they then mix with your food. But in addition to those pancreatic enzymes, we have enzymes in our gut lining. And those enzymes are called brush border enzymes. And those, some of them are actually quite specific. Like, for example, lactase, the enzyme that helps us break down lactose, is made in the brush border. So if you've got inflammation going on in your gut lining and you're not making as many of those brush border enzymes, sometimes we have like secondary intolerances to foods, like a lactose intolerance, for example, because your intestine is already inflamed or already having another problem. So, for example, a lot of times my patients who come in with a celiac diagnosis where they're having an autoimmune response to gluten, they also have secondary lactose intolerance because their brush border has been affected because of the celiac. So once they get that gluten out of their lives and they're able to regrow those villi, and then the villi start making the lactase enzyme, all of a sudden a lot of them can actually tolerate more lactose. So we have both of those enzyme systems going on that could also go awry, right? Um, Another thing that helps break down our food is bile that is released from your gallbladder. It's made in your liver, stored in your gallbladder if you have a gallbladder, and then released as needed into your small intestine to help break up fats and emulsify fats for absorption. If you don't have a gallbladder, like let's say you had stones, or let's say your gallbladder got removed in a surgery, you still have bile, you're still making it in your liver, but you don't have that reservoir, you don't have that like extra amount of bile just hanging around to throw at like a high fat meal like fettuccine alfredo, for example. So a lot of my patients who have had gallbladder removal or who have stones or some sludge in their gallbladder have a certain amount that they can tolerate fat-wise at one time. And then once they go over that amount, they are ending up with fat malabsorption diarrhea, and they're running to the bathroom within like a half an hour of eating. And if that's you, then I would keep that little bit of a food journal so that we can figure out, what is the amount that you can tolerate without causing you symptoms, without like going over that tipping point for you and then ending up with symptoms. Okay. So thinking of the small intestine still, we have basically three parts: the duodenum, the jejunum, or some people call it duodenum. I learned it duodenum, jejunum, ileum, and they have different components and different properties, different things that they do. And I just listed some of the different nutrients that they absorb in these different areas of the small intestine, just to kind of highlight like there's a lot of digestion absorption going on here. And you may not have, like if you've had a gastric bypass, you may not have your duodenum working because it was bypassed. And so think about like some of those nutrients that you might be missing out on, which is why people with bariatric surgery or gastric bypass especially really do need to be supplementing for the rest of their lives, because it is a malabsorptive procedure. So there's a lot going on here. Okay, last but not least, the colon, or the large intestine. This is where we do a lot of our water absorption, mineral absorption, especially like we think about our electrolytes, like sodium, potassium, chloride. This is where your bacteria, hopefully you've got really good beneficial bacteria that are fermenting foods because you are feeding them fibers, and they are making vitamin K. This is vitamin K2, which actually is, it's the MK7 form, the fermented form, which is really helpful for bone health. So sometimes people are not getting enough of this K2 in their lives, and then that is actually contributing to like osteoporosis. This is where we do biotin absorption, absorption of our short chain fatty acid production from our bacteria. So we're going to talk more about this later, but your bacteria, your beneficial bacteria, or your quote unquote probiotics, make what we call postbiotics. And some of the postbiotics, or the molecules that they're making, are short chain fatty acids that can be really anti-inflammatory. Some of those actually go through the body to downregulate things in our body, like downregulate our own cholesterol production. So feeding your bacteria more fiber can help with cholesterol partly from the fiber itself, like sweeping cholesterol out of the body, but also because of this short chain fatty acid production. The majority of our gut bacteria are and should be located in the large intestine. If they are in the small intestine, sometimes that is a disorder called small intestine bacterial overgrowth, which we're going to talk more about next week or in 2 weeks at our next class. And then you may have heard about prebiotics. So prebiotics are basically the things that are feeding your probiotics. And those would be things like fibers and even phytonutrients. So like the colors in our foods, like the colors in our fruits and vegetables, for example. We know now some of those actually feed the microbiome, like polyphenols, for example, in olive oil or in blueberries. So it's not just fiber, but it's actually the color. Just a little plug for colonoscopies. The recommended age is that you start them now at age 45 or younger if you have a family history of colon cancer. Or if you've had any digestive, issues, you might be on a different schedule than that. But if you haven't had your colonoscopy yet and you're over age 45, it's time. I will tell you from experience, they're not that bad. So, okay, let's talk a little bit about poop. So the consistency of stool can tell us a lot about what's going on internally. So if you look at this Bristol stool chart, it goes from dry little rabbit pellets on this number 1. This would be like constipation, then maybe a little bit more together, maybe lumpy and now more well-formed. We're aiming for this like 3 to 4, like ideally smooth, easy to pass. It's all together sausage. And then as you go along this chart here, so more like soft serve ice cream, and then you can get kind of like floaty and fluffy, all the way down to liquidy diarrhea. So think about, your stooling, look at your poop, look at this, the next couple of weeks here, look at the color, the consistency, thinking about your timing as well. How many times are you having a bowel movement per day? If you're not having one every day, how many times per week? If your stool is in this like 1 to 2 range, and or if you are having less than 3 stools a week, that is considered constipation. Now, I will say some of my patients don't think that they have constipation, but they really do because they say, oh, I'm stooling every day. I have a bowel movement every day, but it's kind of dry and it's kind of rabbit pellet-ish. They're like, I can't possibly be constipated. Well, you can be full of stool, like backed up all the way in your large intestine, full of stool, and be having a little bit come out each day. So one of the things that you can do at home just to check this is do a transit check with food that you will easily see in your stool. So like corn is a classic example, or if you don't like corn, you could use something like black beans, for example, but something where it's fibrous enough that you're really going to see that in the stool. So when you eat it, you're going to note the time, see how long it takes to come through and actually see it in the toilet. And, sometimes I've had patients where it takes 4 to 5 days before they see it, and they thought that they were not constipated, but they were really backed up. Really, we should be seeing it within like 24 hours, 36 hours on the outside. So like a day and a half, you should be seeing that come through into your stool. Also, so not just the timing, but color can tell us something. Stool should be various shades of brown. If it's really, really light in color, you might have a lack of bile, or maybe you're like taking a bile sequestrant, or you've got like an anti-diarrheal on board. If you're seeing a lot of like yellow, greasy, floaty stools, that could indicate some fat malabsorption. Green could be excessive bile, but also think about things like, did you have something like we just had St. Patty's Day a month ago? Did you have green food coloring and that's what you're seeing? Same thing with red. Like sometimes people freak out about, oh, I'm seeing blood in my stool, and then they realize, oh yeah, I had beets in my salad at lunch. or you had a lot of tomatoes, or you had some, a red devil cake muffin or something with that food coloring. So do watch out for the colors, but think back through before you call your doctor, because it could just be something that you ate. Black is often seen with iron supplements. That's very common. There's nothing to be concerned about with that. Or if you are taking some Pepto-Bismol, that will often cause black color, or like black licorice. Tarry stool, so sticky and really dark, that is concerning. That could be blood. Some things to try. So here's 2 different lists, one for constipation, one for diarrhea. So with the constipation, less sitting, more narcotics, repetitive motion, walking, anything where you're like doing repetitive movements or twisting movements, increasing your fluids, increasing your fiber. Fluids first before fiber, because if you throw a bunch of fiber at a constipated situation, you can make it worse. So you really need the fluids first and get things moving a little bit, and then slowly increase your fiber over time. Fruits work wonders. So especially fruits with natural laxative properties like kiwi, plums, figs, but fruits in general, because they have the fiber and the fluids together, not bananas and not applesauce. Adding a fiber supplement, again, with that, you would go low and slow. So you'd be gradually increasing that over time, like a teaspoon at a time every 3 to 5 days, with that water increase. Do think about maybe some more coffee. Coffee is actually both a stimulant if it has the caffeine in it, but also coffee has natural laxative properties in it. So, sometimes people will all of a sudden change their coffee routine and then end up with constipation. That can be part of the problem. Any sort of like twisting, folding stretches where you're getting into your abdomen can be helpful, including self-massage. So if you're looking at your tummy, you would be in a clockwise motion, because your large intestine goes up the right side, transverse goes across the middle, and then the left side is the down, where you have like your sigmoid colon. So you would be going clockwise if you're looking at your tummy, and that can actually be really helpful. A magnesium supplement, specifically magnesium that is an osmotic laxative like citrate or oxide. I tend to use oxide with most of my patients. Do ask your dietitian though, or your provider, for some input on this, because if you're on something else, or you have like kidney disease, like we want to be a little careful with that. So just check in with your provider before you just throw a bunch of magnesium at something. And then a lot of my patients just taking the time, like actually having a regimen where you take the time in the morning, you make it a habit, and you're not trying to rush and bypass the bathroom. That can be really helpful for like having a morning constitution. Along with that, I will say we have stronger gastrocolic reflex in the morning, where when we take in something into our stomach, it can trigger a bowel movement lower down. So like a large glass of water in the morning, or your coffee, or breakfast, which a lot of people are skipping breakfast, having that breakfast in the morning and then giving yourself time to actually have a bowel movement, because it stimulates that gastrocolic reflex, that can be really, really helpful. And then lastly, ergonomics. So a lot of times with the ADA toilets we have nowadays that are so high, we are not having proper stooling. Really, you want to get your knees up and like possibly even use a stool, or what you can find online, like the squatty potty, for example. That can be really helpful with the ergonomics of just easier passing of that stool. On the opposite side, thinking about diarrhea, so less stimulants, careful with high fat if you don't have a gallbladder. Stress management can be part of the problem, or part of the solution, right? Sugar alcohols, so anything ending in TOL, like we talked about, and even some of my patients are sensitive to monk fruit. Reducing alcohol intake, adding a fiber supplement. So note that on both constipation and diarrhea, adding a fiber supplement can be helpful. specifically soluble fiber. And the most studied is psyllium fiber, like what you find in Metamucil. And that can actually help for both diarrhea and constipation because the soluble fiber helps absorb the extra liquid and have a more well-formed stool. So it's easier to pass and you're holding that moisture in. So both from a constipation sense, but also from like a sopping up sense with the diarrhea. So the psyllium husk can work for both. Careful with your high dose supplements like vitamin C and turmeric and cinnamon and magnesium. They can be laxatives. You're either irritant laxatives in the case of like vitamin C, turmeric, and cinnamon, or osmotic laxatives in the case of magnesium. Careful with excess exercise. A lot of times we do see this happening for like our marathoners and people who are just doing a lot of exercise. They will have exercise-induced diarrhea. So there's some strategies for that. And then banana rice applesauce toast, the brat diet. So you've probably heard of that. That is basically, you know, things that will help sop up some of that extra liquid and slow things down. Okay, I do want to mention pelvic floor disorders, and I'm going to send a little screening form. You'll get this in your email when you get this recording and you get the slides. If you think this is happening for you, it's definitely worth doing the screening form and maybe talking with your primary care doc to get a referral to a physical therapist to check this out. So there are physical therapists who specialize just in the pelvic floor. So the pelvic floor is basically the bottom of your abdomen. There's 3 different layers of muscles. They're going different directions. Your rectum goes right through all that muscle layer. And so things can go wrong with the muscles, either too much tension, too little tension, a discoordination between what you're thinking you're doing and the muscle movements. Sometimes we have pelvic floor disorders like from birth, like it's just a physical thing. But then for women, we are at more risk of developing a pelvic floor disorder because of pregnancies. And then, of course, like surgeries and things can put us at risk as well. And I do see this in both guys and gals. There's something called dyssynergic defecation, which is like a functional pooping disorder. You would also see a physical therapist specialized in pelvic floor disorders for that. So yeah, definitely something that can be really, really helpful. That is based in like, you know, a physical thing going wrong with those muscles. And I'll send you that screening form so you can think about if that is in line with what you're experiencing. Here are some red flags. So if you're having any of these issues, blood in your stool, black or tarry stool, if you're vomiting or there's blood, you know, if you're vomiting blood or like coffee grounds, sharp pain that won't go away, you're having dizziness, fainting, tachycardia, like rapid heartbeat, or symptoms of shock. If you know you have an ulcer and all of a sudden you're like, oh my gosh, this is way worse. If you're not able to swallow or you're having difficulty swallowing, sudden onset of constipation without a change in anything, like maybe you have a blockage or a stricture or something, jaundice, like yellowing of your skin and eyes, persistent hiccuping that won't go away, new diarrhea, especially if you've been traveling or you've had different, you know, food, could be like an infection, and unexplained nutrient deficiencies like anemia and unexplained weight loss. These are all red flags where you really should be following up with someone. Please do not let any of this go. You need to see someone and get some help. Okay, so that was kind of a quick run through, top down. Get curious about this. Think about what is going on with your digestion. What are your primary complaints, if you have any? Be a little bit curious, be a detective, write some things down. Maybe you do that transit check to see, you know, what your timing is. Again, you're looking for that corn or black bean to be in your stool within 36 hours of eating it. Keep a little bit of a journal with not just your symptoms, but maybe what the situation was. Like, were you stressed out? What was the food? When did this happen? take a look at your poop over the next couple weeks, see what's going on there. Some of the things we identified today, you might, try implementing some of the food behavioral movement strategies we talked about. Reach out to your healthcare team if needed. I'm going to send you that Cozy and Screen, which is pelvic floor screening, but also I'm going to send you a little bloating quiz. If bloating is your main concern, you can take this bloating quiz and start thinking through, like, there's a lot of causes of bloating. Like we talked about the aerophagia today, the intake of too much air, but we'll talk about other causes of bloating next time. And that next class will be on April 17th at 6 p.m. We're going to go over bloating, food intolerances, IBS, which actually has a new name now. We'll talk about that. SIBO, IBD, so inflammatory bowel diseases, low FODMAPs, which is a particular type of nutrition intervention. We'll talk more about fibers. So that was a lot, but we got through it in an hour. Do your detective work, and hopefully I will see you all back here in a couple weeks, and then you'll have more questions and things to share at the time. All right, take care, everybody. Bye-bye.